Hi, this is Syed Zaidi. How are you? Thanks for joining us. And we are happy to host this webinar with a bunch of really strong leaders in the world of population health management. And I'm going to share my slides with you. Give me a second here. So just to launch in quickly here to the definition of population health management, everyone knows that we basically want to keep the patient population as healthy as possible, minimize the need for expensive interventions such as visiting the ER, hospitalization, etc. But we have to develop new skill sets and new infrastructures for delivering care. And the role of radiology is very important here in making sure that we can survive in population health. And how can we bring additional value to the enterprise? We need to be able to advise other doctors through a range of consultative services and acting as a gatekeeper on these services. We can assume responsibility for disease surveillance. And in other parts of this webinar series, we're going to be talking about CDS as well as computerized physician order entry systems. And the role of radiology and analytics for the enterprise level of the organization is also extremely important. And I've been inspired by, Dr. Paul Chang, obviously, who's a leader in radiology IT, to be able to discuss the role of radiology in population health management. And with the help of the ACR, we've come up with this infographic for population health management, which talks about the three phases in the spectrum of PHM. The way that I see it and the committee sees it, it starts with surveillance and prevention. And we're going to be focusing on this today. We have mammography in this category, low-dose chest CT, virtual colonoscopy, AAA screening, and then emerging AI tools. And for today's webinar, we're going to be focusing on mammography, low-dose lung cancer screening, CT, as well as virtual colonoscopy. And then you move into the acute care phase, where you're having the patient interact with the healthcare system. You want to practice ACR imaging 3.0, and then follow choosing wisely criteria. You have best practice recommendations, CDS, and we're going to be doing more webinars on the role of CDS with PHM. And then you have chronic care management, where you want to follow up AAA, lung nodules, oncology and IR. And you have this spectrum of diseases such as fatty liver, metabolic syndrome, where what is the role of AI and radiology in helping to manage people with these chronic diseases. And I'm just going to skip through these slides since we went over this already, basically. So today's webinar is a part of a six-part webinar series where we're going to be focusing on screening. And the reason that we've taken this on is the Population Health Management Committee sits under the Patient and Family Centered Care Commission. And our mission is to engage radiologists and stakeholders on the importance of the role of radiology in population health management. We want to collaborate with other PHM leaders, and just like the leaders that we have today, we want to learn from their experience and disseminate them. Any best practices, any strategic wins, and even points that they struggled and are not doing so well with, so that at least we can learn from that. And we're working with the Lung Cancer Screening 2.0 subcommittee as well, and other internal groups such as the Economics Commission. And I'm proud to be partnered with my co-chair, Ryan Lee, in this effort. So now I'm gonna introduce the the first webinar participant, which is Dr. Lauren Golding. She joins us from the ACR Macro Committee. She's the chair of the ACR Macro Committee. I think she needs no introduction. Chair of the ACR Commission on Ultrasound, Director of Outpatient Imaging at Triad Radiology Associates. And Dr. Golding will be sharing her experience with how effective breast imaging can positively impact the health of patient populations. So please go ahead, Dr. Golden.
Thank you very much, Syed. So I am going to talk about breast cancer screening and how that may fit into population health management. Syed gave a really excellent explanation about what population health is, and in more practical terms, we talk about population health, but what it really is a payment model in economic terms. So if you can think about how to make a population healthier, how to keep your patients healthier, how do you reimburse your physicians in a way that incentivizes them to care for patients in that way? And I'm on the economics commission, so that's how I spend a lot of my time thinking. How can we translate this concept of population health into payment models? So I want to talk a little bit about what that might look like with breast cancer and why I think breast cancer screening is a really good example of how radiologists may have an opportunity to be involved in some of these types of population health models. You've all seen slides like this that show the spectrum from volume-based care to value-based care. And I just want to remind us, since a lot of radiologists are kind of removed from this transition. In our experience in surveys, we find that a lot of radiologists don't participate in APMs, or the ones that are in alternative payment models don't realize they are because they're part of big multi-specialty groups where the care is largely driven by primary care metrics and primary care type attribution methodology. The radiologists may be in those models, but they aren't really participating in a day-to-day way. So we start with fee-for-service, which is how radiologists are traditionally paid. We read a mammogram, we get paid the certain amount from Medicare based on the RVUs for that mammogram or from a commercial payer. If you move one step up, you start talking about episodic payments or bundled payments. So a physician might get a payment for doing a knee replacement or a payment for doing caring for a patient with diabetes. And then they have to figure out the best way to care for that patient that uses the resources most wisely, that gives the patient the quality care that they need, but does it in a way that doesn't necessarily just rack up procedure after procedure. Progressing on, you can get into shared savings agreements, and then eventually into a population-based capitation model. So that's kind of the ultimate population health payment model, where a health system or an insurance company or a physician group is given a set of money to care for a group of people, and they can use those resources however they want in whatever ways that they feel like is most efficient for caring for those patients. So it's not all theoretical. In 2015, the Health and Human Services Secretary made a commitment.
Hey, Lauren, I think we have the wrong screen on. We have it on the slide. You don't have it on presenter mode. Just wanted to let you know.
Oh gosh, thank you, Ryan. Let's see. Is that better?
Awesome. Thank you.
I'm sorry about that. In 2015, the Health and Human Services Secretary made a commitment to transition Medicare payments in the United States to value-based payments or to alternative payments. And that was with a goal of 30% of all Medicare payments in 2016 and 50% in 2018. We're hovering about that 50% mark for 2020 for Medicare. It's a topic of an entirely different lecture, but based on some changes that they made to the shared savings program in Medicare, where clinicians that chose to participate were mandated to take two-sided risk instead of having the option of only one-sided risk. Some of the participation numbers went down, but nonetheless, we're actually seeing a lot of alternative payment models across the country, even if radiologists don't feel like their involvement is at these same numbers. And it's not just the government, it's not just Medicare. Private payers are also really pushing for risk-based contracts and population-type payments. All three of these that you've seen have made commitments to transition their payments to value-based models and risk-based models, and they've made a lot of progress as well. I think a lot of this is regional. I think some parts of the country are seeing more of their commercial payers trying to initiate these risk-based payments than others, but it's certainly something that we're hearing from our members across the country, and it's something that's becoming more and more common. So what about radiologists? So for the large part, we've been left out of these population-based models and these alternative payment models for a lot of reasons. Many of them were designed around primary care type models. Most of the shared savings and the shared losses are based on attribution of patients. And that attribution methodology assigns patients to whoever is the person that takes care of them the most. So it's generally their primary care doctor. Radiologists, it's really hard to attribute as a patient because we see such a wide spectrum of diseases. We see a wide spectrum of clinical conditions. We touch base with more Medicare patients than any other specialty, but we don't really have that relationship with them and that continuity of care. Radiologists, most of us aren't patient facing. We don't have a direct personal interaction with most of our patients. And for these and other reasons, we haven't really fit well into the alternative payment models that exist. That's not exactly a bad thing, and you can talk to some of our radiation oncology colleagues that can confirm that for you. There was a radiation oncology alternative payment model that was released last year. They're still working out the details, but it's a mandatory APM that Medicare came up with, and they said, look, this is how we're going to do it. We're going to pay you a lump sum to take care of this type of cancer with your radiation therapy and this type of cancer with your radiation therapy. And you have to figure out how to do it the most cost-effective way possible. And not just that, but we're going to take some off the top as savings for CMS. Yeah, that model had some problems. It targeted small practices much more than we as the college thought was fair for those small practices. So, radiology not being forced into these payment models isn't necessarily a bad thing. But it's not really a good thing either, because this is a wave in healthcare, and we're moving towards this type of payments. And if radiologists are left outside the circle, we may find ourselves marginalized. We may find ourselves being forced to take different types of payments that we don't really want to. And if we're not at the table helping make those decisions, then I think that could be a problem for us in the future. So what are our opportunities in radiology? I think that, breast screening is the best one that we have. And I'm going to tell you a couple of reasons why. One is that I said radiologists don't really have episodic care. We don't really see a patient across the continuum of disease. Well, that's true, except for in breast imaging. Breast imagers see a patient for a screening mammogram. If that patient gets recalled, the breast imager more or less assumes ownership for that patient's care. They're directing the workup, the management, they're recommending the studies. Now, of course, as the rules state now, the primary care doctor or the referring doctor still has to put in an order for the mammogram or the ultrasound or whatever's next. But I would dare say that in most locations, it's the breast imager who's leading that care. And in many cases, the breast imager is talking to the patient about the results and making recommendations for follow-up. They see the patient after biopsy and discussing the results of biopsy. So in this case, we really do have an episodic kind of bundle here of care that a radiologist can be held accountable for. I think that's unique amongst the specialty of radiology, and it makes breast cancer screening really at the top of the list when we start thinking about how radiologists could participate in population health management. We thought we might have an avenue for coming up with a radiology-based alternative payment model. One of the provisions of the MACRA statute was for the creation of something called physician-focused payment models. And the idea was that specialty societies or other stakeholders, health systems, could submit their ideas for an alternative payment model that allowed specialists to be involved. I won't go through the details here, but there was a committee that would listen to the proposals and decide whether or not they would recommend those to Medicare to be implemented across the country. We put some thought into this, and we thought, hey, maybe we could come up with a breast imaging physician-focused payment model. And this is actually some back of the napkin work that we did at some of the economics people did at a meeting we had when the physician-focused payment model concept first came out. We tried to think about how could we encapsulate the screening process, the breast workup process for breast cancer, into an alternative payment model. And we thought it might go something like this. So you have a patient that has a screening mammogram. If it's normal, they go back to the yearly screening. If it's abnormal, then they go into this workup path. And there, you could do two arms, their pathway where they get say it's a asymmetry that disperses and they don't need anything else and they can go back to screening, or they need a short-term follow-up. Pathway 2 would be more expensive. They need a biopsy or some more expensive workup or intervention. And let's say the radiologists were accountable for a certain cohort of patients, and they were responsible for managing them in this way. We thought about how the episode would be triggered. So you could look at the CPT code for a diagnostic mammogram and ultrasound in combination with an ICD-10 code for an abnormal screening. And then the episode would end either after the patient had a biopsy or a diagnosis was made, or if they returned to screening. So this is conceptually how we thought maybe an alternative payment model for breast imaging would work. Unfortunately, the physician-focused payment model idea really stuck at that. It was an idea. A lot of specialty societies and stakeholders submitted models. The review committee recommended a lot of those models to CMS, but the Health and Human Services Secretary rejected all of them. So none of them actually came to fruition. I think this was largely based on a political agenda at CMS. They had their own models and their own ideas through the Medicare Innovation Center, And they used some parts of some models, but none of them really were implemented. And we ultimately decided that this probably wasn't a viable way for us to get a radiology model out there. But it was an extremely useful process, not only to see what other people's models look like, but to think about what a breast imaging model might look like. Any alternative payment model and any type of population health model really has to have two goals. One of those is to increase the quality of the care that you provide patients, and the other is to reduce the cost of the care that you provide patients. And when you're looking population-wide, that could mean a couple of things. You could increase the quality at the same cost, you could reduce the cost and keep quality the same, or you could make both of them go down. But any model that you bring up that increases the cost is going to be a problem or reduces the quality. So when we're thinking about breast cancer screening, where were the opportunities for cost savings? Where could we reduce costs and save resources for population health? Well, if you had a model where the radiologist was taking ownership of managing the patient's care, you might avoid visits from referrals to breast surgeons. I know in my area, sometimes a primary care doctor will feel a lump in a patient and send them right away to a breast surgeon before they ever get a diagnostic workup. Well, if the radiologist was responsible for those costs of care, then maybe those surgery visits unnecessarily wouldn't happen, and we could prevent some of those visits. Could you avoid visits to a primary care physician or a surgeon to talk about results, since that's already done by the mammographer, if the mammographer were taking a responsibility for that? There could be a penalty for excess recall rates that could reduce costs for practices that were outliers in recall. And those savings could be returned as care coordination fees, so that practices that did this well and saved money for their population, they could reinvest that money in infrastructure and paying for nurse navigators or other things that could keep their population healthier. These were ideas and concepts that we thought would allow radiologists to be involved in these types of models. In what way could we increase the quality of our population of breast imaging patients if we were to have a breast imaging model? Well, we thought that one thing you could do was look at the screening mammogram recall rates and use that as a quality measure. There's a lot of measures, fortunately, in mammography that already exist through MQSA that we could use. Cancer detection rate, positive predictive value of biopsy. And those are already built into a lot of our breast imaging centers and should be easily accessible. There's several MIPS measures that are related to breast imaging that could be used as quality metrics. One thing that I think importantly is to measure patient satisfaction and the patient experience. I talked to several patients that are really frustrated that they have to go pay an extra copay to go see their primary care doctor to talk about results that I just gave them in person as a breast imaging radiologist. I think that there's ways that if we took ownership of that, could improve the patient experience as well. Another potential increase in quality, if breast imagers had their own alternative payment model, would be an opportunity to promote other screening. This has been talked about before, but mammography is a great touch point for patients. And if you're thinking about population health, you're thinking about when can I capture these patients' attention so that I can get them healthier in all the other aspects of their life. So if someone's routinely coming in for their screening mammogram, you've got their attention. You can give them information about screening, lung cancer screening, or colonography, other screening that may not be as common as breast cancer screening. So we talked about how we could potentially increase quality, potentially reduce cost as radiologists in our population health model for breast screening. But now we need a payment methodology. How would we get paid by that? And is it feasible to even think about that? This is an article that Danny Hughes and Rich Duzak and Dr. McGinty and some other colleagues published in the JCR a few years ago. And they looked at whether or not it would be feasible to do a bundled payment for breast screening. And the results were promising that this is possible, that across the country there's enough uniformity in payment. And if you take a large enough population, it wouldn't bankrupt practices to try to do this. So the concern would be, I'm going to take on a payment, but what if my patients are super complex? Or what if my radiologist happened to order more? Or I get a really bad year where I've got a ton of biopsies. Am I going to go bankrupt if I'm taking a bundled payment? This study, I think, helped assuage some of those fears in saying that it would be possible to accept a bundled payment for a population of breast patients. There was a follow-up paper done to this one, also published in the JCR, that looked at tomosynthesis, and did these results hold true for tomosynthesis too? And they did. So that's another encouraging feature. Well, because the physician-focused payment model pathway fell through, we started thinking about what are the other options for getting a radiology-centric alternative payment model out there to give our members the opportunity to participate. CMS came up with what's called a MIPS value pathway, or an MVP. And this is a subset of the MIPS program, where they try to consolidate some of the quality, some of the performance categories. I'm not going to go into the nuances of MIPS because I'll bore you all to death, even more than alternative payment models. But right now, there's 4 separate performance categories. There's quality, there's cost, there's improvement activities, and promoting interoperability. And the measures in each of those 4 categories don't really have anything to do with each other. You pick from a menu in each category. And there's a lot of criticism that it doesn't really measure the quality of care you're providing from patients. You're just basically playing this game. So CMS thought that the MIPS value pathway would be a way to kind of transition clinicians towards alternative payment models. And the thought was, if you could group measures that were alike for the same disease condition, then you could put those into like a mini APM. So you would have a quality measure that had to do with diabetes, and an improvement activity that had to do with diabetes, a cost that had to do with diabetes, and you could put those together. Here's an example that they provided in one of the rulemaking cycles of diabetes prevention and treatment. So they have a couple of quality measures related to maintaining hemoglobin A1C, improvement activities that your practice can do to improve the care for diabetes patients, and then some cost measures that could all be rolled up into that. So, we thought, can we make this into a breast imaging MVP? And I think we can. That's where we currently are. This is the current status quo with our Economics Commission and the Breast Imaging Commission and various other stakeholders in the ACR. We're trying to figure out, can we make a breast imaging MVP, MIPS value pathway? And it would look a lot like what I talked about for the physician-focused payment model. The breast screening episode we could look at. We have to find definable measures. There's obviously lots of nuances to finding a quality measure that measures true quality and doesn't disadvantage anybody who's really providing quality of care, but doesn't look as good on the numbers. Cost measures are a challenge for us, as they are for all physicians in any of these models. But we're trying to figure out ways that we can hold radiologists accountable for the cost of care that we provide as well. So I think I'll stop here. I have some other things to say that I think will piggyback on some of our other speakers, but my time's up. So I'm going to pass it back to Syed, and he's going to introduce our next speaker.
Thank you. Thanks, Lauren. And our next speaker is Dr. Cecilia Brewington. Dr. Brewington is Chief of Community Radiology, Vice Chair of Clinical Operations, and Professor of Radiology at UT Southwestern Medical Center. She also serves as Vice Chair of the ACR Colon Cancer Committee, and we're grateful to have Dr. Brewington here to discuss the role CT colonography can play in improving the health of distinct patient populations. Thank you.
Thank you for that wonderful introduction, Saeed. So first, I'd like to say, we've talked about a lot of things here in terms of population health. So for the context of my discussion, which is going to center around CT colonography, I'd like to somewhat redefine the context of the discussion with radiology and population health. And I'd send a thank you out to several of my fellow radiologists who helped to coin the following definition. So the definition of population health for radiologists, we tend to think of that as the use of evidence-based standardized imaging, radiology therapies, and management to optimize outcomes for a distinct population. So when we talk about colorectal cancer screening, does that fit within the population health definition? And I would say absolutely. Just as with breast imaging and screening, with colorectal cancer screening, we have a defined population, it's greater than 45, and we have standardized imaging and a management plan. So most of you are accustomed to hearing the term BI-RADS, which is used for breast imaging. Well, for colorectal cancer screening, we use CRADS, and it's a very similar structure where we know exactly the next step to take depending on what the findings are. So if we find a polyp that is 3 millimeters in size, what's the next step to take? If it's 6 millimeters in size, what's the next step to take? And that standardized management is based on evidence. And that evidence we know leads to improved outcomes for that population. So with that definition, colorectal cancer screening fits absolutely in terms of population health for radiologists. Now, there are other things that we do at our institution. We're involved in the ACR registry that helps us ensure that the quality is there. So you heard Dr. Golding talk about quality metrics, such as what's your recall rate? What's your sensitivity and specificity? These things have existed for breast imaging for a long time. Well, within colorectal cancer screening, when we talk about CT colonography for that, we can do similar things if we belong to the registry. We can look at our outcomes, our recall rates, and we know what those are. And so it again makes this an optimal thing to do if radiologists want to be involved in population health. And what's the improved outcome for that population? The best outcome we could hope for. It's colorectal cancer prevention. Colorectal cancer is one of the most preventable cancers that we have because we know the natural history. We know how to prevent it, and that is to find the polyp early enough to remove it and prevent the cancer. Now, in some cases, we're not going to have started that process early enough. We're going to, in about 0.03%, find a cancer perhaps. And in that small segment of the population that we're looking at, we'll have the opportunity to find it early. And an early stage of detection is a less costly way to manage a population. It also leads to longevity. So let's take a moment to talk about colorectal cancer screening using CT colonography. So very similar to the process that's been described for breast imaging, those possibilities exist for colorectal cancer screening by radiology. So we not only dictate a report and provide that report to both the provider and the patient, we also educate. So we educate, we talk to the patients about their options in our system. We also collaborate with our GI counterparts to make sure we can follow through on the next steps. So as I mentioned, if we find a polyp and it needs to be removed, we've collaborated with our GI counterparts to ensure they reserve spots on their schedule so that that patient can be seen the same day for that polyp removal with a optical colonoscopy. That allows for an improved patient experience. You don't have to repeat the prep, if you will. So by doing these types of things and working in a collaborative fashion, what we do is we close the loop on this process. We can do this and take care of the patient, own the patient. Just as the previous speaker spoke to, we want to own the process. And by owning the process, we instill trust in the referring physicians that are sending those candidates to us. The family practice physicians, the internists, and other healthcare providers, they don't have the time in the day to pay attention to what's going to happen to that patient once they release that patient into our system. So similar to breast imaging, this was discovered that once they send a patient to us, they need us to own the process and the next steps for the patient. And that's how we close the loop. It's really following the model that breast imaging has set up for us. And I think, in my opinion, that's the optimal way for us to be involved in colorectal cancer screening with CT colonography. Now, what else does CT colonography bring to the table when we talk about how can we benefit our health systems or our hospitals that we're working with? How can we show added benefit? Well, if you look to the right in the graph, you'll see that over the past 25 years, we've seen a drop in cancer deaths by 27%. That is thought to be mostly due to the fact that we're screening for cancers. So we've been impactful by screening for cancers. So whether it be breast screening, lung cancer screening, or colorectal cancer screening, it's making a difference. And if radiologists can participate in that, we are serving the better good. We're helping the patient, we're helping the population, and we're helping our health system or hospital that we're working with. So for our private practice radiologists out there, we're always struggling to show added benefit. And for our other radiologists in academic settings, in large institutions, you're showing added benefit to the APM that you belong to, perhaps. There's also benefit by showing that you have downstream increase in colorectal cancer surgeries. Hospitals always look for the surgeries, but we're going to do that at an earlier stage. That means it's a less costly workup for that patient, less costly management, and everyone benefits from that. And for an ACO or accountable care organization, you're trying to do work for a population at a less cost, or as as the former speaker said, Dr. Golding, at better quality. And better quality is good screening. Now, we know that CT colonography can help to do this. How do we know this? If we look at the literature, in a study done by Cash and et al., for 17,000 patients or candidates for screening for colorectal cancer, they know that when they added CTC or CT colonography to the menu, their screening rates increased. They jumped from 67.9% up to 84%. So we screen more patients. We've known for years that colorectal cancer saves lives, but we can't get everyone to screen. If you offer more options, you may have more screening rates, better screening rates. And this is an option that we need to offer also to the underserved population to increase their screening rates. After all, it's the underserved, uninsured, and underrepresented minority patients who tend to die from colorectal cancer, have it more commonly. So we want to increase their screening rates. Let's take a look for a second at patient navigation. Patient navigators are used with breast imaging programs, but also with colorectal cancer screening, they can be advantageous. If we take a look at a randomized clinical trial offered for optical colonoscopy to non-English speaking and lower income patients, they saw through the use of navigators, patient navigators can be a nurse, they can be an MOA, they can be anyone who's educated in the process of screening. But by adding that person to your program, we saw an increase in the patients who completed the screening event that went from 10% to 21%. In 2008, in another randomized clinical trial using patient navigation, we added CT colonoscopy or colonography or virtual colonoscopy. It goes by both names, and sometimes I use one versus the other. But at the end of the day, what did we see happen in 2008 in that randomized clinical trial? We saw another increase in the screening candidates. It went from 13% to 54%, a statistical difference in the number of patients that we were able to screen by adding a navigator to help assist the patient in knowing what the prep was, knowing how to do it, easing their mind in terms of what that day was going to be like, and getting that ball over the goal line. And so this is what we can do with patient navigation added to a program as an example. Now, our former speaker talked about the risk and benefits of these types of programs to the radiologist. So let's take a break in the discussion on how we do it and talk about what are those benefits and risks when it comes to colorectal cancer screening. Well, as in most programs previously described with MACRA, there's an incentive or a carrot, but if we don't meet the metrics that are required, there can be a stick at the end. And so when it comes to colorectal cancer screening, is CT colonography for the radiologist worth a shot? Well, I'd say when we talk about MACRA and MIPS, CT colonography for colorectal cancer metrics, how much of your population, what percentage of your population is doing screening, is included. Now I'm going to talk about the HEDIS metrics for a second and then bundled payments. So let's go to the next section. So as the former speaker said, quality comprises 40% of the 2021 MIPS categories. Within the MIPS categories is colorectal cancer screening. What percentage are you screening of your population? And so with colorectal cancer screening via CT colonography or virtual colonoscopy, it counts in the numerator of the total number of patients who have had successful screening. So if we do this, we're participating as radiologists. It helps to add to the ACO number of patients that are successfully screened. We also can do this as a MIPS participant in terms of MACRA. We could select colorectal cancer screening as one of our measures that we've chosen because it fits in that category. Now let's take a break and talk about HEDIS. HEDIS is another tool in our tool chest as a quality metric. Over 90% of insurers look at HEDIS metrics to determine if they're doing a great quality job. Well, HEDIS includes CT colonography as one of the metrics that qualifies for colorectal cancer screening. So we've already passed that hurdle. So yet again, this is another way that radiologists can participate in some of those efforts that might be part of the metrics chosen to follow as part of MIPS or as part of the APM if colorectal cancer has been selected. So keep that in mind as a way that we can become involved. Other HEDIS measures for colorectal cancer screening include fecal occult blood testing, the flex sigmoidoscopy, optical colonoscopy, FIT DNA testing, but again, in the yellow, CT colonography is a way that radiologists can participate and share in some of the benefits to be had. But we are also placing ourselves at risk if we're in an APM and we don't meet the metric of getting that population screened. Now, last but not least, I'm going to take out a moment to talk about APMs. And I am very grateful again to Dr. Golden for having done such an excellent job of talking about APMs. Well, an APM is also something that I belong to, being part of a larger institution. We participate in the metrics that they have chosen, and they have chosen lung cancer screening. They've chosen mammography. They've chosen colorectal cancer screening as the metrics that they are following. So by doing CT colonography, we're participating. And if we win, if the health system wins, the ACO that I belong to wins, then we share in that increase in incentive payment to Medicare Part B payments or claims that we file for anything that we do. We see that increase in revenue. So that's the carrot. The stick, of course, if we don't hit those metrics, we're going to be penalized as well, along with our other colleagues in other divisions, other departments. There is also something new that's coming in 2022. In 2022, there will be a mandatory participation in bundled payments from acute care hospitals. All hospitals will have to be a participant in these bundled payments. They'll have to select, and I've given some example, episodes of care that they will follow and track and have benchmarks for to meet the metric. Now, you might ask, how can radiologists play a part in any of these episodes? Well, just as Dr. Golden mentioned, radiologists frequently touch every patient, and especially in an acute care setting, whether it be the CT that's ordered or the ultrasound that's ordered when we're taking care of a stroke patient who needs a carotid ultrasound, or a sepsis patient that needs a CT, we participate. We touch almost every patient. So the way that we can help or assist is by being appropriate, improving the appropriateness of what's ordered during that acute care episode. If we can do that, then we can help our healthcare systems, our ACOs, decrease ultimate costs. And what we do there is help them benefit in a bundled care situation. So the less costly the workup, the less often that patient is readmitted to the hospital, can depend on radiologists offering our advice, our expertise in what should be ordered and how frequent it should be ordered. So that's how we participate. Now, how do we benefit from that? Hospitals are going to eventually turn to the providers and ask their assistance, because if they're not hitting their benchmarks, those come back to how the workup has been taken care of for this patient during that admission or during that readmission. And we are a part of that discussion. And so I would encourage you to pay attention to bundled payments, because they are going to become something that we need to pay attention to. And just as Dr. Golden mentioned, if we're not talking about it now, we may be faced with payment systems that don't involve us, and yet we'll have to follow them. All right, thank you very much for your attention.
Thanks, Sheila. That was fantastic. Next is Dr. Deborah Dyer to provide her perspective on best practices and operational successes in lung cancer screening. Sorry. Dr. Dyer is chair of the ACR Lung Cancer Screening 2.0 Steering Committee, as well as chair of the Department of Radiology at National Jewish Health in Colorado. Dr. Dyer will be presenting her perspectives on best practices in lung cancer screening. Go ahead, Debbie.
Hello. It's wonderful to be with all of you this, for me, it's still afternoon. For you on the East Coast, I think it's evening. So I will talk today about the newly released U.S. Preventive Services Task Force recommendations for lung cancer screening and describe some of the benefits, the timeline for implementation, and the reopening of the Medicare NCD for lung cancer screening CT. I'll describe some best practices in lung cancer screening and some of the current barriers. So here's the good news. On March 9th, 2021, the U.S. Preventive Services Task Force did release their final recommendations with a grade B recommendation, and they decreased the age to start at 50 and the PAC years to 20. There was a nice summary of the recommendation published in JAMA. And to summarize then, what we have is a grade B recommendation still, a recommended start age of 50, minimum PAC years of 20. The task force did keep in place the upper age limit of 80, and they kept in place the 15 years since quit. And this is referred to as the 50-80-20-15 plan. And the benefits of this plan and the drop in age and PAC years is that it will help address the disparities in lung cancer screening. The strategy will, in fact, by modeling, we see that it will increase the relative percentage of persons eligible by 87%, by 80% in men and 96% in women. The new strategy will help address racial disparities, particularly in Blacks and Hispanics, with a relative increase in eligibility of 107% and 112%. Other recommendations within the final task force recommendations are to continue lung cancer screening on an annual basis until the patient is no longer eligible, to use age and smoking history to determine eligibility rather than some of the more elaborate and sophisticated risk models, because the risk models were thought to be a barrier because they're more complex. I mean, granted, lung cancer screening is pretty complex as it is. All current smokers enrolled in screening should receive smoking cessation interventions. Shared decision-making is important, and that the decision to undertake screening should involve a thorough discussion of the potential benefits, limitations, and harms of screening. And LungRads provides guidance on which findings are suspicious for lung cancer, and they may decrease the rate of false positives. The assessment of the net benefit was there is moderate certainty that annual screening for lung cancer with low-dose CT has a moderate net benefit in persons at high risk of lung cancer. So the reason that it wasn't given a grade A is that the grade A recommendation involves a high certainty that there is a substantial benefit. Now, the timeline for implementation is going to be a challenge. Now, because of the ACA, we know that commercial insurance and state Medicaid expansion programs will be required to cover lung cancer screening as they are now. They will, however, have up to 1 year after the new contract year to implement the new criteria for coverage. So that means since the recommendations were released in March 2021, that some plans will have up till January 2023 to implement these new criteria. Now, payers may voluntarily cover the new population sooner, and until new coverage is in place, it'll be our role and referring providers and patients to advocate for screening for our patients. Now, Medicare has agreed to reopen its national coverage determinant. They will be preparing a new draft for their coverage. That'll go out to public comment, and then there'll be a final release. This whole process could take many months and up to 2 years. Now, there is good news in the uptake of lung cancer screening. It has been slow. It is nowhere near what we know we see for breast cancer screening and colon cancer screening. But you can see here, these are the numbers within the ACR registry that it has increased year by year. Of course, in 2020, we did see a drop, but it was really sort of a minimal drop if you think about it, with all the chaos and stoppage of screening programs that we encountered. Now, what do we see as the best practices and the necessary components for lung cancer screening? Certainly there needs to be eligibility screening, and this is, if you will, pre-screening for screening. There needs to be an ordering process in place to document eligibility, that the shared decision-making occurred, and to obtain a pre-auth if it's required. Programs need to have a CT protocol and CT technologists trained in low-dose CT. The radiologists need to be trained in lung rads. There needs to be a tracking system to monitor and remind patients of necessary follow-up and annual exams. We have to participate in the ACR lung cancer screening registry, and smoking cessation interventions have to be offered. So within the best practices, I think it's important to recognize that lung cancer screening is a team effort. A program coordinator or navigator is a must. Programs should hold regular team meetings. Programs do have to have some sort of logistics for sending letters with a summary of results to patients. There needs to be some sort of IT infrastructure or software for tracking patients' exam results and getting that data submitted to the ACR registry. There needs to be a process for referring suspicious nodules to multidisciplinary conferences. And then there needs to be a mechanism for offering smoking cessation resources. And that is ideally done with either navigators or advanced practice providers who are trained as tobacco treatment specialists. And then, of course, there has to be a strategy for handling the incidental findings. So who's on the team? This is a list of the folks that I personally have on my team that I think are absolutely necessary to provide the best practice in lung cancer screening. And you'll notice at the bottom, maybe these are some odd folks to think of on your team, but we have finance and representatives from our hospital administration on our team, and then also marketing. And especially with lung cancer screening, where it's so new and we're trying to educate and promote it inside and outside the hospital, these kind of folks are critical. Now, a structured reporting system is required for Medicare reimbursement. The goal is to decrease false positives and provide consistency in reporting. And the lung rad system was adopted by the ACR in May 2014, and it was updated in 2019. It provides consistent guidelines for follow-up and an S category for significant incidental findings. And here's an example of, this is the latest version, version 1.1 of lung rads. And the category that probably gets the most attention is the lung rads 4 category. These are the suspicious nodules. These are the solid nodules that are larger or growing, or the part solid nodules that have growing solid components. And so here's an example of a case from our program at National Jewish. We found this patient who had a part solid nodule in the periphery of their left lower lobe. They were appropriately given a lung rads 4A with a recommendation for a 3-month follow-up. The patient came back in 3 months, and you can see how that nodule has grown in size, and particularly the solid component has grown. The good news is that this was resected, and the patient had a stage 1 lung cancer. So this was a save, and we had a very grateful patient. Now, the S code is used, as I mentioned, for the significant incidental findings. And these include actionable findings that need medical attention, such as moderate or heavy coronary artery calcification, aortic aneurysm, interstitial lung disease, lymphadenopathy, or solid organ masses. Now, best practices, I think, need to include enhanced patient communication. We've learned from mammography that we need to send a patient-friendly letter to the patient with a summary of CT results. And we also include a copy of the CT report. The referring provider gets a copy of this letter. We have our program navigator call the patient to make sure the letter was received and to find out if there are any questions. We have nurse practitioners that offer follow-up visits with the patients to review the CT results, and this can now be done through telehealth. Importantly, for the LUNGRADS 1 or 2 categories of results, it's important that we can schedule next year's annual CT right when those results are received this year. And then for the LUNGRADS 3 or 4, we contact the patient and make sure they understand the next steps and that further imaging or a procedure is needed and that there will likely be a copay. Now, it's valuable, I think, to optimize the multidisciplinary conference scenario for lung cancer screening. And in the interest of time, I'll just mention that it's useful to just schedule this right after your regular lung tumor board. And this then provides you the opportunity to review these LUNGRADS cases in the setting where you've got all the right players there. We also make a point of inviting the referring providers to attend that conference. And now, of course, they're all done virtually. In my program, we have seen a strong increase in cases each year, about a 20% growth. Of course, that did drop in 2020, and we're slowly recovering in 2021. In our program, I will just want to mention that I think we've been fortunate to have certainly support by our administration to build this sort of program. And just for interest's sake of how we're structured, we have 2 patient navigators, and those are paid for by Radiology. Our centralized program has 5 nurse practitioners that are paid by pulmonary medicine. They do all of the shared decision-making, and they do it every year as a touch point with the patient. They coordinate the care continuum and communicate with the patient and the referring provider. They review the CT results with the patients, and they are trained tobacco treatment specialists. As I mentioned, we've grown about 20% every year, and our navigators and radiologists coordinate our weekly nodule conference. Our cancer detection rate has been 1.7%, and 85% of our cancers have been stage 1. Our success, I think, is due to a strong team effort. Now, of course, there are the barriers. There's no question that we have a lack of awareness among patients and providers, and boy, these new recommendations are going to add to some confusion as well. Unique to lung cancer screening is the guilt and stigma around smoking. We do have complex eligibility requirements. They're not just based on age. There is the requirement for shared decision-making. We have provider concerns about how to deal with positive results and incidental findings. We have to have data entry into the ACR lung cancer screening registry. And then there are financial concerns that the reimbursement is relatively low when you think about all the additional added tasks. So our challenge is right now only about 4 to 12% of eligible patients are getting screened. That means there are about 9 million Americans that are currently eligible. With the new task force recommendations, that number will probably double. So we have a lot of work to do. In summary then, lung cancer screening is a team effort. It's a program, not just a CT. The new recommendations will help address the disparities in lung cancer screening. Structured reporting with LUNGRADS allows for consistent reporting and helps decrease false positives. Suspicious nodules should be referred to multidisciplinary suspicious nodule conference for further review. And the barriers to lung cancer screening are significant, but are being addressed by coordinated efforts with our stakeholder groups. So I thank you, and I welcome any questions, or for further information, feel free to contact me.
Sounds good, Dr. Dyer. Thank you so much. And I'd like to transition us to the Q&A portion of the presentation. Q&A will be led by Dr. Ryan Lee. Dr. Lee is Vice Chair of Quality and Safety for Radiology at the Einstein Healthcare Network in Philadelphia. And Dr. Lee is also co-chair of our Population Health Management Committee of ACR's Patient and Family Centered Care Commission. Go ahead, Ryan. Thank you.
Thanks, Saeed. No, we definitely went over because we had some fantastic material, and it just goes to show that radiology really has a significant, if not central, role in population health. So I think we have time for maybe one question for each panelist, and time for just a short summary from each of our speakers. So Dr. Dye, I'd like to start with you just to follow up on your talk since you had just finished. Let me just bring up my question here. How do you think screening programs should handle patients who meet the new criteria in the meantime before the new guidelines are adopted?
And that is going to be a challenge. Our program and many programs I know have already a structure for having self-pay patients who meet the NCCN Group 2, which happen to be the age 50 and 20 pack years. So if you have a process in place where you already maybe know the group of folks that meet those criteria, it is possible that their insurance may cover them this year. And so we are going to be reaching out to the commercial providers to see if they will cover. So we're telling the patient on the phone, there is a chance that you won't have to be self-pay this year and that you may be covered. So I think it's an opportunity, and importantly, it's also an opportunity to educate and perhaps nag a little the insurers.
Sure. And I guess it's even more complicated because you're going to have that discussion with each third-party payer.
Yes.
Lots of work to do. Thank you. Thank you so much for your talk.
Sure.
Dr. Brewington, how can radiology and population health management address health disparities?
Thank you for that question, Ryan. So, I think radiologists are seeking to play their part in addressing health disparities. And things that we need to think about are our hours of operation, for example. If we can be impactful in making a change wherever we're practicing and when we're offering things like screening, for breast screening, for colorectal cancer screening, for lung cancer screening, we can be very impactful. We can also look at where those locations are. For our health institution, for example, we have some sites that are located in the community. And it might be a good idea to open up services on the weekends. For our mammography, of course, we have the benefit of having the mobile van be accessible. So we can take it into the community, because that, as we already know, when we're talking about the underinsured or uninsured or underrepresented minorities, they have to deal frequently with what life is giving them right here and now. And when we talk about screening, that's not something that's affecting them right now. By virtue of the definition, screening is for an asymptomatic candidate. And if you don't have it now, what's your priority? Is your priority your children? Is your priority your job? Probably so. And so to have screening occur and benefit those underrepresented minorities and decrease health disparities, we've got to meet the patient where they need to be met, closer to their place of living or work, and make it accessible to them on their time.
And your program is just a fantastic example of how radiology is poised to be in a position to understand and meet those disparities and to overcome them as well.
Well, I think we are poised to do that. Of course, that doesn't mean the battle's over. So we have to convince others of how important this is as well for us to play a role. And then we've got to do some work also on our own colleagues, because of course we prefer to work at certain times of the day, but we've got to think bigger. We've got to think about how we can be impactful, and getting back to our mission of why we went into practice medicine.
For sure, I agree. Thank you so much, Dr. Brewington.
Thank you.
Dr. Golding, in your talk earlier, you had talked about how an MVP can look like for breast imaging in radiology. Do you have any idea how MVP could work for diagnostic radiologists, other diagnostic radiologists not in breast imaging? And we don't even know what's going to happen or when it's going to happen or how it ultimately looks like, but how could that look in another DR example?
Yeah, you really didn't give me long enough to answer this question, but I'll give you a 30-second quick answer. There's a lot of, the problem with the MVPs is that CMS has been really vague in what they expect. They've given us some kind of broad examples, and the sticking point for all specialties is going to be what kind of cost measures to use. Even in the ones, the examples that they gave of the surgery and a diabetic patient, the cost measures were both total cost of care measures. So that surgeon who does the cholecystectomy on someone is going to be held accountable for the referring for the hospitalist ordering a diagnostic mammogram on the patient because they just happen to be there, or ordering extra tests every day. And is that fair or not? And you can argue that all you want, but the real sticking point is going to be those cost measures. And that's even harder for radiologists, because how are you going to hold a radiologist accountable, a diagnostic radiologist, for a total cost of care in a patient's workup? And we haven't answered those questions yet. I will tell you one thing that we've thought about is in a diagnostic radiology world is, could a radiologist be held accountable for the follow-up of incidental findings? Could we take ownership of that? Could we see a patient who's got an incidental renal lesion? Could we meet with that patient? Could we talk with them, share decision-making, decide what the management should be, make sure that they get follow-up, or what a biopsy or whatever they need? Could we coordinate that from our end, instead of referring that out to whatever specialty, organ system it has to be? That's one thing that we thought about doing. There's some regulatory barriers that keep us from doing that right now that we're working at trying to get down. But I think the common theme in everybody's talk that I heard today that I really like is this team-based concept. And I think that's the only way radiologists have forward here, is that we have to see ourselves as team players. We are one of a team of clinicians that are trying to do the right thing for the patient and trying to reduce the cost of healthcare. Any way that we can do that is helpful, whether it's trying to get our patients colon cancer screening so that our clinicians can increase their screening rates and have those colon cancers found early, or working with our lung cancer screening programs and nurse navigators and techs and marketers and everyone trying to get the patients in. And as long as we're viewing ourselves as teammates, then I think that's really our key to our involvement in population health, whether it's in our health systems or hospitals, in our groups, or in our communities. So I don't have a good answer for MVPs, but I think that should be our focus going forward.
Yeah, you're absolutely right. Looking at the programs that Dr. Dyer and Dr. Brewington presented, it did strike me as the multidisciplinary approach to a successful screening program. So I completely agree with you.